coming back for the second of my ECG webinars. So to recap, 2 weeks ago we covered the ECG basics, and hopefully that's all fresh in your mind. But if not, we have put this on YouTube, so if at any stage you want to be reminded of the content, please look it up. You'll be able to access by just going into the YouTube search bar and typing in ECG basics, put my name or Southampton Cardiology Society, and it should pop up. You can ignore all the other ECG videos. I'm sure mine will be the one that you want to access. Now, this week we are going to cover acute coronary syndrome, and of course, acute coronary syndrome I think is something that, particularly when you're just starting out as a doctor, you worry about quite a lot, because you're worried about missing the diagnosis. You're worried about the complications that might ensue from ACS, and often people are worried about calling the cardiology rich, which isn't something that we think is right. But hopefully it can give you a bit of confidence with this lecture about interpreting ECGs and giving you more confidence with picking up the phone and talking to us, and we're always very willing to do that. Just as a reminder, in 2 weeks' time, we'll be going through tachyarrhythmias, so when things go fast, so probably something people are even more worried about than ACS. And then a week after that, we're going to cover bradyarrhythmias, so when things go slow, which is also very concerning, but people tend to be a bit more comfortable with. So let's begin. Acute coronary syndrome. So ACS is what is the acronym for acute coronary syndrome, and let's just go a little bit of background to give a bit of perspective here. ACS is more of an umbrella term, more than a specific diagnosis. It covers everything from unstable angina through what is NSTEMI or NST ACS, through to an ST elevation myocardial infarction. What it does not include is stable angina. Everything under the ACS umbrella is serious and requires hospital admission and investigation and treatment. The difference between these is not purely based on the ECG, but also based upon troponin measurements and historical assessment as well. All of these are caused by an imbalance in the supply and demand of coronary perfusion. That doesn't necessarily mean that the coronaries have to be blocked, but it is a problem of either supply or demand. And this is when we weigh up the scales of supply and demand, this is what we see. Now, you may have heard of the terms of type 1 and type 2 myocardial infarction. Type 1 myocardial infarction is where we have some sort of coronary blockage or occlusion, which impedes the flow of blood and therefore oxygen, glucose and other nutrients to the myocardium, and therefore the myocardium infarcts. However, of course, that's not the only way that you can impair the supply of oxygen or nutrients to the myocardium. You, of course, can cause by hypoxia or PE. It could be caused by having a tachyarrhythmia, where your heart is pumping so fast that you can't perfuse your coronaries as well as you'd like to. So there's lots and lots of other things. However, the thing that people probably worry about the most, and of course what we're probably going to be focusing a bit more on, is having patent, or in this case, not having patent coronary arteries. When you go and see a patient who has chest pain, you're probably thinking, is this person having MI? And you're probably in the back of mind actually thinking, does this patient have patent coronary arteries? But you will subconsciously be assessing all of these other things at the same time. And this is what we're talking about. So this is a coronary angiogram. A coronary angiogram is an invasive test where you flush dye down the coronary arteries of a patient. This can be done via access, in which this case it would be the femoral artery, so the big artery in the groin, through the radial artery, usually the right radial artery, and you thread it all the way up the arm, down to the aorta and down to the start of the coronary arteries. What you do is you thread a catheter, a very, very thin straw, goes all the way around the aorta and right to the start of the coronary ostia and dies flushed down there. In this case, we are looking at the left coronary arteries. So right, if we look right here, if you can see my arrow key, the catheter has entered the left main stem, which in this case is quite short, and dye has been flushed down here. The left main stem divides into the left anterior descending artery and the left circumflex artery. The circumflex is the one that's going north to south on this diagram, and the LAD is the one that's going left to right after the left main stem. And where the arrow is where there's an occlusion. So that nice thick black line should be continuing all the way to the apex of the heart, and it's not because it's included by a thrombus. So ACS, how does it present? Well, I'm sure you all know that ACS, typically you have a patient who comes in with chest pain, breathlessness, but it's not always that. Some people can present atypically, and it could be any of the cardiovascular symptoms. I particularly get caught out sometimes by patients being just generally unwell, particularly those who are older and unable to express themselves as well. If a person's looking clammy and generally unwell and is not quite right, be a little bit suspicious that ACS could be a diagnosis. Or, and this is probably more common, the patient can be completely asymptomatic when you see them, because when they've been called out the ambulance, the paramedics have gone out there and they've really sorted them out exceptionally well. And by the time they've got to the emergency department, they're asymptomatic, and all they can give you is the history, and you won't be actually able to visualize the symptoms as such that are in front of you. Why is ACS bad? People die from ACS. ACS, or heart disease, is still the #1 leading cause for death in this country. Morbidity. Heart attacks cause a large amount of morbidity, not only from things like heart failure, but also from arrhythmias. Patients with ACS are more likely to have other complications such as stroke, and people with ACS also are more likely to get other perhaps conditions you wouldn't normally associate. So things like depression also manifests more in patients who have had ACS. Investigations, you're going to do a catalogue of normal investigations that's going to come out with a patient you're suspecting of ACS, and all of these will probably be done automatically for you when they come to the emergency department. But of course, what you want is the ECG, and that's what we're going to talk about today. The ECG is going to be the quickest test that you are going to get. You're going to get it within a matter of minutes when a patient comes in, and it is instantly going to give you a way to triage the patient. Is this patient having an ST elevation MI, or is your ECG completely normal, which gives you a bit more reassurance. So let's go through the ECG. ECG in ACS. So things to think about. When you have your coronaries and you have a blockage in your coronaries, the occlusion can either be a total occlusion or a threatened occlusion. If it is a total occlusion, no blood is getting down that coronary artery from that point where it is blocked, and that is going to lead to myocardial anoxia from that point downwards. None of that myocardium in that territory is going to get any oxygen or any nutrients, and thus that part of the heart is going to die unless it is unblocked. Threatened coronary occlusion, which may be, say, from a plaque rupture and then you have a thrombus, but there's just a little thread, a bit of blood getting through, will lead to myocardial hypoxia. But of course, some of the myocardium will be getting hardly any oxygen or nutrients at all, and that part will be threatening to die as well. In general, typically, a total coronary occlusion will lead to a STEMI, whilst a threatened coronary occlusion will lead to an NSTEMI. It's not 100%, but that's typically what happens. Now, of course, what we covered last 2 weeks ago was that the heart is a very highly adapted electrical conductor controlled by a catalogue of different ion channels, which help the depolarization of the heart, the repolarization, and everything happens in a beautiful synchronized fashion. But if you have hypoxia or anoxia to an area of the heart, and that area is going to affect the active functioning of these ion channels, and therefore they will become dysfunctional, and therefore the depolarization and repolarization of that part of the myocardium is going to change. And because of that, we can detect this on an ECG from the moment we have a deficit in oxygen or nutrients to that part of the myocardium. And your ECG changes that you will see are affected by a number of things. Firstly, the coronary artery that is affected, and that was we'll come on to that in terms of the different anatomy of the coronary arteries and where you'll see that in your ECG. The size of the territory, of course, the larger the worse. And if you're thinking about an occlusion as well, if you occlude the top of your left anterior descending artery, everything downstream of that is threatening to infarct. So it could be a very, very large territory, very large amount of myocardium that could infarct. If it's just right at the end of the obtuse marginal artery, which is an artery that comes off of the circumflex artery, it's obviously going to be a much smaller territory, and therefore a much smaller amount will be seen on the ECG. Transmural versus subendocardial. That's a very posh way of saying a full thickness infarct, which will be a STEMI, versus a partial infarct, which is shown as an NSTEMI. When we say subendocardial, of course, the coronary arteries run epicardially. They run around the outside of the heart, and therefore, if there's an occlusion, the part of muscle that is furthest away from the coronary artery is going to be the endocardium. And of course, that is going to infarct first and then move progressively towards the epicardium. It is subendocardial because the first layer of the endocardium will just receive oxygen from the cavities of the heart themselves. Reperfusion. Sometimes coronary arteries, if they are occluded, will just open up again, the clot will disperse and go away, or of course it'll be caused by us, either by primary PCI or thrombolysis. And the agent of the infarct, ECG changes on through ACS will be very different if a patient has come in 10 minutes from their infarct to if they've come in 6 weeks later. So we're going to move progressively through unstable angina, NSTEMIs to STEMIs because the changes are different between the two. So we'll start with unstable angina and NSTEMIs. So the first thing to say is that when I was in medical school about 10 years ago, these were two separate diagnoses. And the reason that NSTEMI or NST-ACS now has become a lot more prevalent and unstable angina has not is because the sensitivity of our troponin test is so dang good now that anyone that has any tiny amount of infarction we can detect on a troponin test. Therefore, people with unstable angina, which by definition is no myocardial death or necrosis at all, and having a negative troponin is actually quite uncommon. However, the two diagnoses still exist, and however, you will be treating these essentially the same way. It represents subendocardial ischemia, as we mentioned, and this is what I mean by subendocardial ischemia. We may remember this diagram roughly from 2 weeks ago. This is the cavity, let's call it the left ventricular cavity. This is the endocardium, this is the epicardium, and this is a subendocardial infarct affecting not the full thickness of the myocardium. ECG hallmark features that you will see: T-wave inversion and ST depression. So let's go through those. Firstly, T-wave inversion. The first thing to say about changes you see in the ECG with NSTEMIs is that often they could be very non-specific. There are very many causes of T-wave inversion, and that NSTEMIs are just one of them. However, there are certain features about T-wave inversion which, when you look at them, makes you a bit more suspicious that this might be an MI as opposed to some other cause. And these are if the T wave inversion is more than 1 millimeter deep. Okay, that should be greater than 1 millimeter deep, not 1 millimeter deep. If it is greater than 1 millimeter deep, that is much more concerning. If you have two continuous leads with T wave inversion with dominant R waves, that is also concerning for T wave inversion. Dynamic. So what do I mean by those two areas there? Well, first off, let's talk about the T wave inversion with dominant R waves. Now, you may remember this diagram again from 2 weeks ago. This is the pattern of depolarization and relopolarization of the heart. Now, what we're going to focus on is these two large arrows right down here, representing ventricular depolarization and ventricular repolarization. The red arrow, of course, occurs first. The depolarization will occur normally, but the repolarization in an end-STEMI, instead of occurring from the epicardium to the endocardium, and remember we've reversed the arrow here because a repolarization from the epicardium to the endocardium is probably easier to think about as a depolarization as such from the endocardium to the epicardium, actually no longer occurs in that direction, but occurs in the opposite direction. The repolarization is now going to occur from where the infarct is occurring, so let's say here, outwards, and therefore if you think about it as a depolarization as such in the opposite direction, that makes it much more easier to think about. So now what we're seeing is a depolarization in one direction, so the true ventricular depolarization, and then a repolarization going in the same direction. So thinking about it as a depolarization in the opposite direction. So now you have the R wave, a depolarization in one direction and repolarizing in the opposite direction. So what I'm saying is the ECG, the R wave will go up and the T wave is going to go down, and that's not normal. They should both be in the same direction in general. Coming back here, I also mentioned dynamicism. So what do we mean by that? Well, what we mean is that if you take a series of ECGs 10 minutes apart, then you will see changes between the two, or 2, 3, 4, 5. Why is that useful? If you're seeing dynamic changes on the ECG and not fixed changes, that means there is ongoing ischemia. And why is that? Well, if you're having a deprivation of oxygen to an area of tissue, that tissue will continue to function until it can function no more. And it will just slowly start to lose function. If it's slowly losing function, then electrical changes in the heart will be progressive, and they will change and change and change and change. So some ion channels will working, not working as well, not working as well, not working as well, stop working. And of course, the area where this is affecting will also change. So if you're having a progressive change in the amount of hypoxia, anoxia, and cell death within the heart, then you'll be able to detect that on an ECG as it progresses. So you might get a T wave that's inverted, and then more inverted, and even deeper and inverted. So basically your changes, if they are dynamic, represent ongoing ischemia. That is very specific for ACS. So this is our typical ECG pattern that we'll see probably in like V4, V5, V6. This is what T wave inversion looks like. R wave is course up, T wave is going down. And that might be something you might see at the start of an end-STEMI, but you may see something that looks like this. That is big, deep T wave inversion. That is very, very concerning. And here is a good example of dynamicism. The start of the T wave inverting in A, so it's actually what we call biphasic, some up, some down. And then B, coming more progressively down, C, really quite deep, and then D, really, really, really deep. Let's take a look at a few examples. So here's an ECG from a patient who is having some chest pain, breathlessness, very typical sounding for an MI. And you can see in leads V2, V3, and V4 that the T wave, which is typically going to go up, is going down. Okay, that is not normal. Now, you may say to me, well, Alex, V2 is going down, V3 is going, it's a RSR pattern, V3 is an RSR pattern, and the T waves are now going down. They're going the same direction. Shouldn't that be normal? That is completely true. That is a very reasonable thing to say. You have to appreciate that none of these anatomical rules are particularly 100%. And the diagrams we use are, of course, 2D, and you have to think of it as a more of the heart as a 3D structure. So actually, some of the depolarization and repolarization doesn't occur perfectly along the same axis. V2, V3, and V4 typically would normally have an upright T wave, and next time they are down. Here is another very good example of a thing we call Wellens syndrome. Wellens syndrome has very deep T wave inversion through V2, V3, V4, and often progresses all the way through to V5 and V6 as well. ST depression. Once again, there are several causes of ST depression. And actually, it's very, very similar to T wave inversion in the way that when we become concerned or not. So these are the concerning things for ischemia. If the ST segment is horizontal or flat, or if the ST segment is going downwards, that is more concerning. If the ST depression is significant, so if you have the isoelectric line and the ST depression is much, much lower than that, greater than just half a small box, then that's more concerning. 2 continuous leads is more concerning because that suggests it's a larger area of the heart that's being concerned. And again, dynamic changes, and probably most importantly, dynamic changes. So what will this look like? First off, you can have upsloping ST depression. This is less concerning. There's a differential for this, and we don't get too worried about upsloping ST depression. I won't go into too much more details about that. That can go on for a long time. These are what we're more concerned about. So downsloping ST depression and flat ST depression. You will also see that the ST depression often merges into the T wave and gives the T wave a quite an unusual appearance. Sometimes it's biphasic, and it often makes it look very, very unusual. This unusual ST and T wave morphology gets us very concerned. Let's take look at a few examples here. So here we have in V2, V3, and V4 quite significant ST depression. It is downsloping from the J point. Remember that the J point from a couple of weeks ago is the point on the ECG where the QRS complex then merges with the ST segment. Downsloping V2, V3, V4, and probably about normal now in V5, V6. Now, some of you may have looked at that ECG and been pulling your hair out. And the reason for that we'll come on to later. But for ST depression, you must always remember, could ST depression be reciprocal changes of a STEMI? So when I look at this, and when you look at ST depression, you see it in V2, V3, V4. You have a think about what the territory that is involved in that, and think about why this ECG specifically is more concerning than perhaps if there was ST depression in a different territory. And we'll come on to that in a bit. Right, so we're going to now move on to ST elevation MIs. I think it's probably a good time to have a break, see if there's any questions. Are there any questions, Mohammed?
Nothing in the chat at the moment. So yeah, if you guys do have any questions, just make sure you drop them in.
So again, no questions?
Yeah, nothing at the moment, no.
No questions at the moment. Must be going very well. Okay, let's move on to STEMIs then. So STEMIs. STEMIs are a medical emergency. STEMIs are, yeah, we get very worried about STEMIs. If you have a patient who's having an ST elevation MI, we will be coming immediately. And the reason for this is you're having a full thickness MI. A full thickness MI means a large amount of myocardium is at risk of dying. If a large amount of myocardium is at risk of dying, these patients are at risk of dying. They are susceptible to having malignant arrhythmias. And what do I mean by that? I mean at risk of having VT and VF and just going down and dying. A lot of people with STEMIs will not even make it into hospital. So this is very, very concerning. People that do survive having had a STEMI, even if they've had treatment and had a good outcome, are often associated with severe morbidity and large amounts of heart failure, and they often do not return to the life they once had. That's my very fancy technical diagram showing a transmural infarct, but I'm sure you get the point. Now, STEMIs have progressive features on an ECG, and some of these can catch people out. This is the progression that you will see from a STEMIs. Hyperacute T waves is the one that might catch you out, but usually only occurs in the first 5 to 10 minutes of a patient having STEMI. ST elevation, I don't think any of you will miss, because if you do see it, you'll be very, very concerned and you'll be asking for help. When you start to see gradual loss of the R wave, i.e. when the QRS is meant to be going up and it's starting to get smaller and smaller and smaller, and Q waves start to appear, i.e. the first thing after the isoelectric line, the first thing after the P wave is going down, and it's going down quite a lot, that's very concerning, and that's suggesting that part of myocardium is dead. That's very concerning. And then later on, the ST elevation will resolve. That means that there's no longer any infarct going on and everything is dead. Hopefully we don't get to that stage. So, ST elevation. There are criteria for this. Often ST elevation can catch people up, particularly if it's just a small amount of ST elevation, like 1/4 of a millimeter, 1/2 a millimeter. I'm not quite sure if it's ST elevation. They've got a bit of chest pain, but it doesn't really fit. There are specific criteria that we look for, but of course this is all in the context of also what the patient looks like and what their history is as well. Typical criteria that we look at are if there's greater than 2 millimeters of ST elevation in 2 continuous chest leads, or greater than 1 millimeter in 2 continuous limb leads. Now, continuous chest leads is fairly straightforward because they're all anatomically in order. Limb leads are not anatomically in order, and when I say 2 continuous limb leads, I mean 2 anatomically continuous limb leads. So I'm talking of things like lead 2 and lead 3, lead 3 and AVF. Those are inferior leads. Maybe lead 1 and AVL, they're both lateral looking leads. So that's what I mean by continuous limb leads. Yes, I don't think that requires any more explanation, but bundle branch block paced ECGs are challenging, but they are not uninterpretable. And I'm sure many a junior doctor will look at an ECG and say, paced, can't do anything. That is completely not true. If a patient has a bundle branch block or has a paced ECG, have a look at it all the same, because if a patient is having a STEMI, you'll probably be able to identify it because the ECG will not look normal. So, first thing you'll see in a patient who is having a STEMI. So you've had a patient who's having a STEMI on the ward. This is the first thing you will see. This is a peaked T wave, much kind of like a hyperkalemic type change, but the QRS is not widened. Nice big T wave, very disproportionate to what you would expect. And so here's an example. V2, V3, V4, V5, V6, all very concerning, all very peaky, large T waves, even larger than the QRS complex. Very, very concerning T waves. Then the bit where your diagnosis just comes out very, very clearly. Your ST segment elevates. So you notice here, it is no longer QRS complex at all. There's a Q, there's an R, and then the S, well, you don't get an S, you get to the ST segment because repolarization is occurring much more early, which is an effect that the anoxia has had upon the myocardium, and the ST segment begins. So here is an example of a STEMI. looking even V1 actually in this patient, but V2, V3 definitely, V4 definitely. The ST segment is raised. It is a couple of millimeters above the isoelectric line, and the T wave is also inverting. Q wave development. So this is probably a patient who's been having a STEMI and had it for some time. We're talking probably in the realms of more 4 or 5 hours now. Q waves start to develop. Q waves are synonymous with parts of the myocardium dying. And when you're seeing a Q wave, when I say that, I mean the full thickness of the myocardium is about to die. So here is a patient who has got significant Q waves in leads 3 and AVF. I'm just having a little quick look around. You may also notice there's an ST depression in lead 1, and perhaps could I argue V6 as well. Here the Q waves with the bit of ST elevation in 3, 3, 3 and AVF signifies a patient who has had or is having an ST elevation MI, but the part of the myocardium is getting to the point where it is no longer salvageable. And then resolution of ST elevation. If we've got to this point, we have a Q wave, there's no ST elevation, the myocardium has died. This is the point where there's no myocardium salvageable. Of course, at this point, often patients find that they haven't got any chest pain anymore because that part of the myocardium that was infarcting or was infarcting has now infarcted. So there's no lactic acid there. The piece of tissue is dead and they don't have any pain anymore. You sometimes will see this ECG pattern in patients who said, a few days ago, I had some indigestion, some chest discomfort, felt a bit breathless, and I just kind of wanted to man up and didn't see the doctor about it. But now I feel really breathless and I've decided to come down, and you'll see something like this. And it's always quite disheartening because you know what happened 3 days ago and you know you could have done something more for that patient at that time, but now you're much more limited in what you can offer. So here is a patient who V1, V2, V3, V4 as well. It's got Q waves, but the ST elevation has resolved. You can, as you probably noticed, the ST segment doesn't look quite normal. It's quite curvy. And the T wave is also inverted all the way through down to V5 and V6 actually as well. So to take you through each of the ECGs as we move through a STEMI, a normal ECG, peaked T wave, ST elevation, Q wave development, and then ST elevation resolves. Okay, so we've been through NSTEMIs and we've been through STEMIs as well. Does anyone have any questions at this point in time?
There's no more questions in the chat. You do very well.
All right, thank you very much. So now we're going to move on to anatomy. So it is one thing to be able to identify a patient having an NSTEMI or a STEMI, and of course you're going to have the ECG and you may have some troponins, you have some other things to help you. But taking it to the next level now, the ECG can tell you so much more about what's going on with the patient. So thankfully, cardiac anatomy is not that complicated. For ACS, the things I want you to know is I really want you to know about the territories where the patient is having an MI. Things to know: there's a left coronary artery and a right coronary artery. The left coronary artery divides into two, what we call the LAD, the left anterior descending, and the circumflex. The LAD has branches that come off it, and they are called the diagonal branches. It also has some septal perforators. The LAD covers the anterior part of the left ventricle. The circumflex travels around the heart in the atrioventricular groove on the left and supplies the lateral wall of the heart and also the inferior wall. If the circumflex has the posterior descending artery come off of it, then it will also supply the posterior part of the heart. The right coronary artery supplies the right ventricle. It supplies the SA node. In 90% of circumstances, it will supply the AV node, what we would call a dominant right coronary artery. And then most of the time, it will also supply the posterior part of the heart and give off the posterior descending artery. Now, as we mentioned before, there are different ECG leads and they travel around the side of the body in the chest leads. And this allows you to have a look at different parts of the heart and different walls of the heart from the position they are in. So V2 and V3, if you draw a line between V2 and V3 to that area called WCT, if you look at the left ventricle more than the right, that is going to be looking at the septal part of the myocardium, this area here. V3 and V4 also be looking at the front of the heart, but particularly look at this diagram on the left here. If you imagine not just the heart having two chambers there, but also enclosing itself around the front, that is going to look at the front wall. That is a very, very large amount of myocardium that is going to be supplied by the anterior leads. V4 also looking at the anterior, but now getting towards a little bit more lateral, V5 and V6. Of course, that is mainly in 2 dimensions, looking at the heart in that direction. If you want to look at the inferior wall, the bit going down towards the feet, then you're going to have to use the limb leads, and the leads you want to use there are the red leads here, AVF 2 and 3. If you want to look at the lateral wall of the heart, lateral left ventricle, then alongside V5 and V6, you're also blessed with lead 1 and AVL as well. So you may remember this from 2 weeks ago where you knew where all the different leads of the ECG are. You also need to know this. This isn't as easy because it's all over the place, but if you remember your anatomy and where all this comes from, this is very, very straightforward. Of course, knowing that different walls of the heart, the anterior wall, the lateral, the inferior wall, also correlates with the blood supply in the arteries, the LAD, the circumflex, and the right coronary artery. That's useful because if a patient is having an ST elevation MI, and we know it's in inferior leads, it makes us much more aware of where we're likely to have to treat. It also means that we can be aware of complications, because if we have an inferior STEMI and we know that the right coronary artery 90% of the time will supply the AV node, then if the AV node becomes infarcted and doesn't function, then we know the patient is going to be at risk of having bradyarrhythmias. If the patient is having an anterior STEMI, knowing that that whole large area of heart is going to potentially be infarcted, we're going to be more aware that this patient is going to develop pulmonary edema because the left ventricle cannot pump as efficiently as it should do. So, going back to our example here, there's ST elevation in V2, V3, V4. This is typical of an anterior myocardial infarction. So how about we present it? This is this patient's ECG taken at this time, at this date. We know that the calibration is normal. The rate is approximately 80 beats per minute. The rhythm is regular. The axis, more challenging. I would say there's slight right axis deviation. There are P waves present. There are P waves for every QRS, and there are QRSs for every P wave. The QRS is narrow. There is ST elevation in V1, V2, V3, V4, with T wave inversion in V3, V4, V5. There are no reciprocal changes viewable. I cannot see a U wave. This is consistent with an anterior ST elevation myocardial infarction. How about this one? Well, here we have ST elevation in leads 3 and AVF, and there's Q waves there as well. And we also mentioned in lateral leads, there's a little of ST depression. So this is consistent with an inferior ST elevation MI with reciprocal changes in lateral leads. How about this one? So here we have ST elevation in leads 2, 3, and AVF. We have ST depression in lead 1, AVL. And I should probably say that's about it, to be honest. Perhaps some ST depression in V2, which is quite curious. But also you will notice that the P waves and QRS complexes do not align. And this is because this patient has also got complete heart block alongside their inferior ST elevation MI. So here we have an inferior STEMI with a complication associated with the inferior STEMI. So this patient needs to have urgent revascularization, and hopefully that will cure their bradyarrhythmia, which thankfully isn't that slow. Now this one, you may remember we were saying we were coming back to this one. Here we have ST depression in V2, V3, and V4. So we're thinking, okay, maybe it's an anterior end STEMI, and yeah, I suppose it could be. But the thing you have to worry about in these patients, particularly if you see ST depression in V2, V3, V4, alarm bells need to be going, because if you look here, our leads of an ECG, they're great at looking at the front of the heart. They're great at looking at the side of the heart. They're good at looking at the underside of the heart, but they are terrible at looking at the back of the heart. This is where you may have heard of leads V7, V8, and V9 come in. They are leads that just continue to go around the body, and they look at the back wall of the heart, which we call the posterior wall of the heart. Okay. If you have ST depression in V2, V3, V4, you actually may be looking at an infarction not at the anterior part of the heart, but the posterior part of the heart. And also that may be a STEMI for that area. Because if you have an infarction of the posterior wall, ST elevation may occur in V7, V8, and V9. But if you look at it from the opposite side, that will look like a depression. That is what I mean by reciprocal changes. So here, if you string up V7, V8, V9, which have been put where V4, V5, and V6 are, you can see actually that is ST elevation. And V1, V2, V3 are showing the ST depression. So what you were looking at there the entire time were reciprocal changes. Okay, so difficult areas. This isn't very long, so we'll just whittle through this. Bundle branch block. So this is a patient with left bundle branch block. I know a lot of people get het up about having, is it a left bundle branch block? Is it a right bundle branch block? In short, if the QRS is widened, if you're presented this ECG by a consultant on CCU, it's probably going to be a bundle branch block. If you may have learned William Marrow, which is WLM MRW. William being that in V1 you have a W, and V6 you have an M. I.e. in V1 it goes down, and V6 it goes up, and the L in the middle of that means it's a left bundle, and Marrow is the opposite. When it goes up in V1 and looks like an M, and goes down in V6, and it's an R in the middle of that, so it's a right bundle branch block. Of course, every ECG does not conform to that perfect way of remembering it. I would say we generally look at V1, and if it goes down, it's a left. If it goes up, it's a right. That's the thing to think about. There are other small tricks you can use. I won't bore you with all the small, tiny details that you can go into. patients with left bundle branch block, a couple of years ago, if a patient had a new left bundle branch block with the presence of chest pain, that was considered an ST elevation MI, and that required activation of the primary PCI lab, and patients moved forward to primary have a coronary angiogram, and if there was a blockage, primary PCI. But it was found that an extraordinary number of patients with what were felt to be new left bundle branch blocks were going for emergency coronary angiography, and a large number did not require that. And that's because patients had a left bundle branch block and they just didn't have an ECG beforehand, so we consider it to be new, and the chest pain was maybe not. So left bundle branch block is a difficult area. If you have a left bundle branch block in ECG and a patient's got chest pain, the thing to be worried about is, do they look like they're having an MI? Is the history and everything else consistent? And the next thing to say is, a left bundle branch block is a large STEMI. It is taking out your left anterior and left posterior division of your left bundle branch of your left bundles. The whole thing is infarcting. So it's a very large myocardial infarction. So these people will tend to look absolutely horrendous, and then you know that this is an ST elevation MI. The left bundle also can often give you certain changes. So it's very difficult to look at the J point here, because it's actually quite elevated. It's up here, here. The key things to know about: is it dynamic? Is it changing? And what does the patient look like? And do you have old ECGs? That's what we need to look at. This is a right bundle branch block. You can see how V1 is going up predominantly, but V6 is not predominantly going down. I would be able to argue that actually it starts to go down with a Q, then an R, then an S. So you could say that's a W. This is a right bundle branch block. This is paced. You see pacing spikes. You may not see pacing spikes these days, but here you see a pacing spike. This is a pacing the atrium. Don't typically see that. Pacing the ventricle, and then you get a widened QRS. So to interpret patients who have right bundle, left bundle paced rhythm, there are specific criteria you can use. Feel free to look at the modified Scarbosa criteria. They're probably most popular used. But the most important thing to do is, what does the patient look like, and is the ECG changing? And if there is concern, then escalate it then. This is the next one that often gets misconstrued as an ST elevation MI. This is left ventricular hypertrophy. The key things to look at here are, firstly, the ECG is calibrated correctly. You see here on the left hand side, the ECG QRS complexes are very large. So we're talking, oh gosh, 1, 2, 3, 4, 5, 6, 7, 8 and a bit in an RSR pattern, and then going up 1, 2, 3, 4. So in total, we're probably talking about 12 or 13 large boxes if you add the largest down with the largest up. Anything above 7 large boxes is consistent with LVH. You often see this ST depression with LVH. That is associated with repolarization abnormality because the heart is so large. Why are the complexes so big? Well, if you've got LVH and your heart muscle is bigger, you've got more muscle to depolarize, and it takes longer to get round. So it's a larger QRS, it's a wider QRS, and there's often repolarization abnormality because as repolarization will start to occur at the same time as depolarization, and it can often occur in the opposite direction. So once again, to separate out LVH from, is this patient having an NSTEMI? What does the patient look like? What's the history? Are the ECG changes dynamic? And often, have they got an echo? Often the echo will tell you if the patient has got a large amount of LVH. I won't go through this in too much detail, but a classic question you might get asked either as a student or when you're on the CCU ward round is what is the differential diagnosis for ST elevation? and here are your answers to not worry, because you'll always get STEMI, but it's not always the cause. It's the cause you should probably be most worried about. But these are the things that you can also say, and they all give you subtle changes in your ST segment that can give you ST elevation. And of course, this is what we all worry about, and this is what we'll cover in 2 weeks' time. This is a tachyarrhythmia. So that concludes our talk on ACS and the ECG. I hope that was informative for everyone. In 2 weeks' time, we'll be going through tachyarrhythmias, which obviously a lot of people do find very, very frightening. And hopefully I can shed some light on them and make them a little bit more decipherable for everyone. Does anyone have any questions?
Yeah, so thanks for that talk. I'm looking at the chat now, and there's still nothing in the chat. I did have one message from someone saying that they weren't able to see the chat. So if anyone does have any further questions about anything Dr. Bays has just mentioned, or anything at all about the rest of the lecture, feel free to unmute yourself and ask that now if you want.
I just wanted to, I just wanted to ask if you could repeat why the ST elevation occurs in the ECG. So what is the reason for it electrophysiological?
Okay, so that gets more complicated. So we can absolutely go through that. So I thought this may come up. So ST elevation and ST depression are actually misnomers for what is actually occurring electrically. So let's go through ST depression. So this is going to get a bit more technical. So when you have an infarct occurring, what happens is that the ion channels start to become dysfunctional. They start to depolarize early. Their membrane potential is raised. So instead of being a nice kind of plateau isoelectric -90, it's more about -50. And then it repolarizes much, much earlier. And the reason for that is because there becomes a lack of ATP. And there's a lack of ATP. That opens up these new channels, which are called potassium ATP channels, which are usually shut when ATP is about, but when ATP is not about, they open. So the heart depolarizes a bit earlier, and it repolarizes earlier as well, meaning it's often ready to go again sooner than necessary. So what happens here is, hopefully I'm going to get this perfectly right. At the same time, ventricular depolarization is going to occur. The infarct here in red is also depolarizing, and it depolarizes away from the site, because depolarization will propagate from any site where it is firing from. If you have an electrode right here where the infarct is, you are going to detect something coming towards you. So your isoelectric line is going to be raised because you can detect something coming towards you. Once the entire myocardium has depolarized, everything is in the same plateaued phase. So therefore, when it comes, the QRS will come all the way down to the isoelectric point, which is going to be down here. But as it is, now everything's the same, it is much lower than normal. And then when everything repolarizes, it comes back up to this other level. This is quite technical to explain, but essentially the reason for it is that the infarct is another site when you put an electrode over it that actually raises what you believe to be the isoelectric line here up rather than actually having something lowered down. If you take this, which is a transmural, an ST elevation infarct, then if you have an electrode right here, right where the infarct is occurring, you cannot detect, you detect minimal electrical activity, and the only electrical activity you can find from here is going away from the heart. So therefore, if you think something's going away, your isoelectric line will go down. It'll be much lower than normal. Then the ST elevation, the QRS, you have depolarization of the ventricle. It then occurs, again, you get a QRS complex, and then the isoelectric line, now everything is in a depolarized state, goes back to what is the original isoelectric line, which is elevated in this circumstance. And then you get repolarization and everything's back to normal with the infarct still there, which gives you a raised which has got a lowered isoelectric line. I'm going to admit, I don't think I explained that particularly well. It's quite complicated and quite difficult to get across without several diagrams. I would thoroughly recommend that if you are interested in knowing precisely why the ST elevation or depression occurs, definitely if you go onto YouTube and you put in ST elevation ECG, there are a series of videos that are very, very good at trying to explain it, and they spend a good 15-20 minutes just explaining these concepts, and they really get it over very, very well.
Okay, thank you very much.
You're welcome. I'm sorry that wasn't a little bit more clear.
Great, thanks for that. Does anyone else have any further questions? No, that's fine then. I think we'll leave it there. Yeah, so thanks again, Dr. Bates, for your talk. It was really useful for us all. Your next talk then will be in 2 weeks' time on tachyarrhythmias. If everyone wants to check social media for any updates that we have on Dr. Bates' ECG series and additional teaching sessions that we're running, yeah, just make sure that you're following us on Facebook and Insta, and all the information will be on there. And thanks again, everyone, for attending.
Thank you.
Thank you.
Thank you.
You're welcome.
Thank you.
Thank you.